get this going. Well, thank you for doing this.
Yeah.
It's super special to get people to help me teach, and then also my students get somebody other than me to tell them stuff, and then maybe they'll believe you because you actually do it instead of me who doesn't do it. So hi class, welcome. I'm recording now. This is you met previously my other neighbor, Renee, who has expertise in gender, and we just talked about that, and so they've seen at this point the discussion I had with her yesterday, which was really fun.
Yeah.
I think you would have loved it. You would have loved to be there and just hear. I mean, she's an actual expert. She teaches women's studies at Cal State Fullerton, and she's like so well versed in the history of everything. And it's like, I end up.
I'll have to sign up for that lecture for your class.
Yeah. I end up just studying on my own and not having been taught that particular part of the subject that I teach to the students. And I also, in this sense, I don't have any formal training in teaching labor, delivery. It's all been my own self-study, and I haven't done any sort of clinical practice in it. I've only been at 5 live births. That's it.
Yeah.
That's my experience. And so I brought a heavy hitter here. Would you like to introduce yourself to the class and tell them who you are and what you do? And she's my other neighbor, so I have really smart neighbors.
My name's Kathryn Roberts. I'm a nurse midwife, and I've been practicing since 2014. So a little over 6 years now. I work at Kaiser here in Sacramento. And being a nurse midwife, primarily what I do is prenatal visits, contraception visits. Here at Kaiser, a lot of the work that I also do is labor and delivery and the postpartum period as well. But as a nurse midwife, I'm also trained in women's health, reproductive health throughout the lifespan. So from the time that a woman hits puberty all the way through to menopause, that's my scope, essentially. And then I also do some on-call work as a sexual assault forensic examiner with the Bear Clinic here in Sacramento as well.
Well, maybe later we could touch on that if you're willing to,
Yeah. Mm-hmm.
Because that's something that we talk about later in the class is sexual violence.
Mm-hmm.
And that's something that a lot of people don't talk about and don't specifically know anybody who has expertise in the area.
Right.
And when we keep silent about things and we don't have public conversations about them, they tend to be pushed down and then not exposed and not corrected.
Yeah.
And so that might be a really helpful conversation that we could have in the future. Today, what I would love to hear about from you is your expertise on the labor and delivery side. This week in our class we're studying pregnancy, which we've kind of through right now with the lecture that I did on what's happening in utero during different stages of development. If you saw my video, one of the big takeaways I have is don't ever read the book What to Expect When Expecting, because you think that every baby will die a horrible, horrible death.
That's true.
And the worst thing for women in labor, prior to labor and delivery, is stress. The worst thing possible for them. And that the literature and even our narrative is that they are somehow sick and that they are somehow impaired, or that this isn't natural and they need to be coiffed or taken care of. And the reality is that if this wasn't a natural, pregnancy wasn't a natural development, none of us would be here.
Right.
And what I don't have expertise on, and what I'd love to hear from you, is what are the stages of the beginning parts of labor, and then what happens to a woman when she is preparing to give birth, and then not only from the physical side, but from the side of medical professionals who help women do that.
Okay. So the physiology of labor, you are asking about that specifically?
Yeah.
So there's usually, we call labor happens in 3 different stages. So the first stage can actually even be broken down into a couple more parts. The stage 1 of labor is all the early stuff where the body, we call it like the warm-up phase, where the uterus starts to contract, but it's not super regular or really strong. just kind of getting in the zone, just like you would for a sports event, right? Like a muscle.
Is that somehow, I've heard Braxton Hicks called the pre-real labor contractions. Is that another name for this warm-up, or is this warm-up a separate thing from the Braxton Hicks contractions? People
Separate.
might, okay.
Totally separate. Braxton Hicks usually don't have any sort of pattern to them. They can range anywhere from like not feeling them at all to being uncomfortable. But for the biggest part about Braxton Hicks is there's no regular pattern and there's no increase in intensity. It's just random. So you'll hear women or people who are pregnant say, you know, I've been having contractions all day. When you ask them what that means, like, well, I had one and it was every 10 minutes, but then I didn't have one for 2 hours, and then I went 5 hours, took a nap, and then I had one every 10 minutes again. It's really random. And that can, usually those practice contractions tend to happen more frequently for women who have had, or people who are pregnant who have had babies before.
Okay.
So who are on their second, third, fourth kid, and happen earlier in the pregnancy the more kids you've had.
So it's an important thing for you as someone, a medical professional who's helping women, to know if they've had children before, because it will help you discern the signs of what's happening during their labor.
Right. Yeah. And that's one of the biggest questions that we get in prenatal visits is, how am I going to know when I'm in labor? Everybody wants to know, especially first-time moms, right?
Do mothers who have given birth have that same question, or do they kind of understand from an experiential standpoint, I'm going to know when I'm in labor?
I think it depends. A lot of women, there's becoming a larger and larger majority of women who are being induced for their labors because of medical conditions or just because of personal preference.
Okay.
And there is literature coming out that supports some of that, some newer literature in this past year especially. And so a lot of women who have been induced don't know what it's like to go into natural labor. And so if it is their second or third baby and they've always been induced or had a scheduled C-section, then they still haven't experienced that yet, and we'll still have those same questions.
It's funny, I asked you that question, and then my experience with our first child, my wife, when she delivered our first child, she delivered at like 5 in the afternoon, and her doctor who came in said she was exhausted because she had done 6 C-sections that day. They were all planned, all done on that day because it was December 31st.
Ah, tax benefits.
So she was exhausted by the time Becca was ready to give birth, but she was just like, "Well, thankfully I'm not scrubbing in for this delivery."
Yeah.
So it was pretty funny.
And I think, in a lot of private hospitals or private practices, you'll still find some of that practice where there is scheduled inductions or scheduled C-sections for the medical professionals' benefit or convenience, right? Like, I need to be home by 5, or I want to have Christmas off with my family, let's schedule you before or after. But I think that's starting to go by the wayside as that was recognized that was happening, especially in some of the larger hospital systems like Sutter and Kaiser, where people are on call all the time and aren't getting called in from home. There's no reason to schedule anybody for convenience because we're just there. Okay.
I think I can understand that as a critique of practice in the medical profession, but I also kind of feel like people who are helping in labor and delivery are also people, and having them be sharp and fresh and alert and aware and ready, to me, seems like a great idea. So if they can plan for that might have a benefit as well.
Yeah, and that's one of the reasons we don't schedule inductions overnight, right? Over a night shift. We do just schedule them during the day. But when you think, that was one of the hardest parts too about choosing which track to take as a nurse midwife. You can choose to be a home birth midwife, or be in a birth center, or be in the hospital, or some combination of all three. But usually if you're doing home birth or birth center, you're on call almost all the time.
And so you just have to be ready to go.
Anytime. Unless you have a partner or you're part of a larger practice. And that being on call 24/7 is is really wearing.
It constantly sits on your shoulder, just like, maybe I can't fully engage in something else. Maybe I'm going to have to go.
Is my phone charged? We're going to have to take 2 cars. Do I have my scrubs in the back? Do I have my ID? I can't have a beverage. Like, it's
like a on-call pilot or something.
Yeah, exactly. So the benefit of shift work or working at a hospital is that you get that work-life balance, but then you lose some of that patient continuity, getting to see
the relationship
throughout.
The relationship that develops between the patient and the medical practitioner.
Right.
Yeah.
Which for labor and birth
special
is really special.
I remember every single one of the nurse midwives that delivered my boys, and they're special people, and that is a moment that you share in a heightened sense of emotionality with somebody that does create a significant bond. Having been in surgeries, I know that relationship can go only one direction sometimes.
Yeah.
Because of the clinical side of what you're doing as a practitioner in the operating theater, in the delivery theater, you have a clinical side of it that might feign a relatedness for patient care purposes, and that really only some of them are really special to you. Considering how many you've experienced, you're still going to have your stories, you're still going to remember those moments, you can still go back within your memory and experience that again, but that's not with everybody. And certainly for me, I remember all of those women who were the nurse midwives that first one was delivered by OBGYN, and then the next 2 were Kaiser midwives. And it was very, very poignant for me. I'm sure they wouldn't recognize us from Adam, but for us, for my wife and I, we really remember them. Right. So that's something that you have to know, is that you're going to be very special to somebody when you're participating in this process.
Yeah, and that it is a lot easier to have that sort of relationship in a smaller practice. So, in a huge HMO like Kaiser, where I see, 20 plus patients a day in my prenatal clinic, and then I can do up to, I think the most births that I've done in a shift has been 6 or 7.
Oh my goodness.
Which is, it's a really hard, long day. And so it's just sheer number of people. It's a little bit harder to keep all of those memories, but there's still some very special people. And then it is really hard if I see somebody in my prenatal clinic for their whole pregnancy and then I'm not there for their birth.
Right. So those are the sort of the give and the take, the balance of private practice work with smaller group clients versus working in a hospital setting where you are seeing a large number of patients. You're talking about the labor initial stages is broken down into 3 parts. Right. So what were those 3 parts of the initial phase of labor?
So the early phase is kind of that warm-up period that we were talking about before, which is usually, it used to be designated by how many centimeters dilated you are. That's kind of falling by the wayside as we find that a lot of people have different experiences.
That again is referring to the cervix. As the progression of delivery is happening, there's effacement that's happening, so there's this thinning, and then there's also the dilation, which is the spreading open of that cervical os. So if you remember from the anatomy portion, when she's referring to this, it's the changes that are occurring in the cervix as a result of the initiation of the labor.
Right. And that, old school thinking was, you're this much dilated, you must be in this phase of labor. You're this much dilated, you must be in this phase.
That's what I've always heard.
But the cervical dilation is actually such a small part of the labor process. There's just this huge focus on let me check your cervix. That's my finger, checking the cervix. But that's such a small part of that. Because you could have somebody who's 2 centimeters writhing in pain with really, really strong contractions, and by definition, she's in early labor, right? Okay. Based on the dilation only. But 30 minutes from then, she could be...
It could just go so quickly.
Right.
It's not going to be the exact process of flip a hourglass over and, you're 2 centimeters, so we have 4 hours before you're 4, Right. It's not that predictive.
Correct.
Okay.
Yeah.
Yeah, I've always thought of it as the measurements of dilation would say, well, how ready is the uterus to allow out this baby? And what you're saying is there's a lot of variability in that, so that's not something that can be sort of the indicator as a sole variable for when the transition from first to second stage of labor is happening?
Right.
Okay.
So, yeah, that first part, that early part of labor is usually, as far as dilation goes, anywhere from 1 to 6 centimeters. We used to think it was 3 centimeters, and then we were admitting people, and they were like not going into labor for days, and then we're providing all these interventions. And so even during my time of practice within the last 6 years, literature has come out that shows like maybe around 6 centimeters, if you can even call a dilation like a hard line, is to say early labor versus active labor. So those are the
For
first
all of
two
you
stages.
Imperialists out there who use inches, this is approximately like 5 inches is the max you're going to get to. 6? 10 centimeters is like 6 inches?
Yeah.
So 6 centimeters would be, it's 2.54 centimeters per inch, so that's 2-ish? Yeah. So what she's referring to is she'll be able to measure the dilation as almost a gauge, a measurement with her fingers, not like, you don't sit in there and measure with a ruler.
No.
So that's going to be, again, something that's developed over time in practice, is understanding how the bodies are ready for delivery and transitioning from labor to labor. And that's through practice. That's not through like you have a digital meter that's reading the edges of the cervix.
It's always funny to me when I go in and to check a patient. That's what we call checking a cervix, check a patient. And they'll ask me, or their partner will ask me, do you need us to turn the lights on? Like, no, it's all in the dark. It's okay.
Turn the lights on, huh?
Yeah. I'm not going to see inside your vagina with any more lights on. Like, it's okay.
I joke laughingly that there is a cognitive concept that somehow the vagina is a tube or like a hole that you could see through.
Yeah.
And until the very last stages of labor, it is not.
No.
Until the very last stages of labor, there's no way to visualize this. You would have to use your fingers, and so
right.
As you insert your fingers, you're seeing, you're going to touch if the head of the baby is there, and then you're going to then spread them out, or do you spread them out first to say, okay, I know that this is like a certain part of labor, and that the further I get, and I know that this is something indicating to me delivery is almost imminent.
Yeah, so when you do a cervical exam, there are 5 separate pieces that you're looking for, actually, not just dilation.
Okay.
So when I go in, one of the first things that I'm assessing is where is the cervix in relation to the vagina.
Has it set down further, or is it still retracted up inside the...
Right.
Okay.
So the categories for that are posterior, so way far back inside the vagina, mid position, so it's starting to move forward and descend, or anterior, like it's right behind the pubic bone. So when I put my fingers in, if I have to reach, and I tell people it might feel like I'm reaching for your tonsils, right? If I have to get my hand all the way back there, that's a really posterior cervix.
Okay.
And that posterior is usually not
progressing.
So the term that we use is cervical ripeness or readiness, which ripe is such a weird term. It makes
it's a
it
weird
sound like
word,
a fruit.
but we get the idea of it's in the stages of ripening. It's getting ready. It's progressing from one position to another. And so we talk about, in terms of anatomy, you've got the inner third of the vagina where the cervix sits, and so that would be its natural position. But then as labor is happening, the uterus is pushing down further and further by the contractions.
Right.
So you'll feel that approaching the precipice, basically, as labor progresses.
Right.
So that's one of those measurements.
Yep. So position of the cervix, the effacement of the cervix is the other thing. So when we talk about this with patients, we describe it as like the tube of a turtleneck sweater. So if you're pulling ahead through the tube of the sweater, if nothing is in that tube, it's long and thick, right? But as soon as something starts to come in, it gets stretched out and overall gets thinner.
Where's my little gator? I could do a demonstration with my gator.
Yeah,
over my head.
right. But then, so the thinning out, effacement, is another thing that we check. And so the thicker a cervix is,
the less progressed.
Right, or just the closer to normal, right? So posterior cervix, a thick cervix, these are all things that are not, that are like baseline
Okay.
when a woman's not in labor. So position, effacement, we do check dilation.
Okay.
So obviously the lower numbers earlier on in the labor, 1 to 10, that's what we check. And then the feel of the cervix, how does it feel?
Okay.
So usually if you're a person with the cervix and you reach in to feel your cervix now, which a lot of people do, especially if they have IUDs, right. To check the strings. It should feel like the
We
tip of
haven't
your...
gotten to strings yet of IUDs,
sorry.
but we'll talk about them. And the idea is the intrauterine device is in the uterus, and there are strings that hang down out of the cervical os that are capable of being touched and felt and palpated if you wish.
Yes.
And also can help to remove the IUD
Right.
by a physician or by a nurse practitioner. Okay.
Right. Not
so
recommended to
don't
do that at home.
Don't do it by yourself at home.
But it usually a cervix will feel like the tip of your nose.
Okay.
For a woman who's or a person who's not in labor, and then as the labor progresses, it gets softer.
Okay. The softening of the cervix as well.
So when we're describing it, is it like hard like a rock, or is it kind of soft and mushy?
Okay.
And when I'm teaching interns or nurse midwife students, a softening cervix usually feels like chicken fat. And I know that sounds kind of gross, but it's just squishy and malleable, and you kind of can get lost in it.
Okay. So that's something that they would have experience with, and therefore if they recognize that again, they're like, oh, that's what she meant by the ripening of the cervix. Okay.
And then the final piece is descent of the baby.
Okay.
So we are theoretically measuring from the ischial spines within the pelvic bone. Did you guys go over that?
We didn't cover that extent of pelvic anatomy.
It's the narrowest part of the pelvis.
Your butt bones, what you sit on, are your ischial tuberosities, and so they're measuring where is the baby in relationship to a standard point of bone structure.
Right, the narrowest part of the pelvis. Essentially, I want to know, is the baby above that narrow part or below that the narrowest part. If it has started to descend past the narrowest part, that's a really good sign, because a lot of babies get hung up on the narrowest part if they're in a funky position or the contractions aren't strong enough that can keep them from molding and coming through that narrow piece.
So those are the things that transition you into, you're in the second stage of labor now?
Yeah, so checking the cervix, right? We talked about position, so probably an anterior cervix. We talked about effacement, so a really thin, a really soft cervix, and then starting to feel what we call engagement or descent. So feeling the head pushing against the cervix, moving through the pelvis.
So I've never been pregnant or delivered. Does a woman feel the sense of where the baby is during delivery and could sort of tell you, like, the baby is descended now?
A lot of women who have had babies before can. They'll be like, it's in the vagina, like, you need to get ready. Okay.
So
and I listen to them.
It might be one of those things where you don't know what's happening in an initial phase, which is probably the reason why the second oldest profession is nurse midwives. Is that they need some help sort of knowing what's happening during the delivery, but then as they have experienced this before, the second time around, they'll have a real clear indication from a physical standpoint of what's going on.
I think, as a nurse midwife, one of the things that we're taught is one of our biggest things that we can do is to do nothing.
Listen to the patient.
That's why
sit there.
A lot of nurse midwives knit. We learn how to knit, especially if you're in home birth or birth center, because if you're sitting back and your hands are busy,
you're not going to be needlessly active.
Right. Now there are times when intervening is appropriate and safe, and that's like why we have babies that are surviving and moms that are surviving their labors, because we intervene. But most of the time, for healthy, low-risk women, not intervening is one of the best things that you can do. And so the biggest thing then that I think that women need, especially people who are pregnant need, when they reach that active labor phase. So we talked about the first part of the first stage of labor, which is the early labor phase, that kind of warming up, getting regular, getting more intense. The active labor phase is usually considered about 6 centimeters. You've got that really ripe cervix, And also, it's a lot harder to cope. That's usually when it takes that person's total concentration. They are not able to focus on anything else, and it's when they start needing support a lot more. And so that's one of the biggest things that people need, is just emotional support. It's really, I always find this interesting. There's a study that shows, an older study, but still, that shows that even if you put a woman who's laboring in a room with another woman, but that woman is behind a curtain and not doing anything at all, that woman will still feel more emotionally supported than a woman who's completely alone.
Wow.
So just that, like, just being there. So many times I have partners saying, I don't know what to do, I don't know what to say, I don't know how to support, and it's just being there is one of the biggest things you can do.
From an experiential standpoint, we absolutely feel that way. There's something of the acculturated masculinity that makes us want to do something. And so that can be very difficult. But if we listen to the expert, the thing to do is to be there.
Be there.
Rather than do anything, it's to be there. And so that's a really important thing to remember for, we've been talking a lot about physically what a woman's going through in labor. Hopefully if she has a supportive partner who's there, that he can know he is actively participating by his presence, and that it's not something necessarily more he needs to be doing or creating chaos. Right. Just be there.
Right, and be present, right? Not talking about the partner who's in the corner on their phone or in and out getting coffee.
If you're going to get on the phone, just get behind the curtain, because that's what the studies say, right?
Just be present.
You're going to be more emotionally supported.
Yeah, so that emotional support piece and that true, the contractions at that point are very regular, increasing in intensity over time.
I'm just checking the camera. You can keep going.
Yeah, that's okay.
This way I can see it now. Okay. Zoom.
And then getting to that final stage of the final part of that first stage of labor, the third piece of that first stage, is called transition. And that's when the uterus is transitioning from opening to pushing down. And that traditionally is those last 3 centimeters, about when you're getting into that 8, 9, 10 realm.
Okay.
And you'll find that's when a lot of people start to say, I can't do it. A lot of people ask for medications during that time. A lot of people get very primal. So those animal moans, the song of the person in labor, very, very vocal at that time, because it's a truly kind of out of this world experience as the baby makes that final descent into the vaginal canal and the uterus pulls back and pushes all the way down. It's really, really intense, and then that leads to the second stage of labor, which is the pushing.
So that's an interesting thing. So the transition is, as you were describing, the uterus is initially opening up, and then once it's opened up sufficiently, then it sort of transitions to power from behind to push out.
Right.
Okay. And the second stage is pushing, but can we talk about how does a woman know when it's good to push and when it's not, in terms of if she's experiencing too much pain to engage in the pushing versus sort of getting up the energy to do so? How do you figure out how to encourage a patient to do that?
So again, stepping back to that non-intervention, a lot of the time if I just step back, the body is going to start to do it anyways. And that there's a name for that called the fetal ejection reflex, meaning once that baby is in that position and the uterus is at its maximum force and dilation, that strength or that push, the person is going to start pushing on their own. They're not going to be able to stop.
So this is not a volitional activity of pushing at some point, right? Because I've heard a lot of times women who are in that second stage of labor being encouraged to push with their contractions, right? So to tighten down their pelvic and their abdominal wall muscles, their lower back muscles, to increase the force with which the uterus is pushing.
Right.
But what you're saying is, even if they don't, say she's unconscious, some godforsaken accident happened, she's okay. Sorry.
That's okay. What were you gonna say?
You were talking about that at that point, a woman feels an urge like she normally does to use the restroom.
Yeah.
I was just translating for you, she wants to poop.
Yeah.
Because it's not like she wants to pee. That's not the sensation.
No, sorry. And I mean, it sounds crass, but especially for a person who has never had a baby before, that is something that they are used to doing all the time, right? So when you say it's going to feel like...
That gives them an anchor to sort of sense for the way the muscles are going to be feeling as they're experiencing that.
Right. And this is particularly helpful for people who are numb from an epidural, right? Trying to make that connection.
Okay.
Okay, I have pooped every day, probably, of my adult life. Like, I know how to do that.
Mm-hmm.
I know what muscles are involved when I sit on the toilet. And that's a good starting point to help bring that force back. But if they have an epidural and the contractions are strong enough, it's what we call passive descent or laboring down. That head, once the cervix is completely dilated and thinned out, the head will continue to move down with the strength of the contractions, whether you're pushing or not.
Okay. And this is second stage of labor.
Correct.
First stage of labor can take a very, very long time.
Yeah.
But second stage of labor has less variability in the amount of time it has?
Usually.
Okay.
Mm-hmm.
So that's when women are admitted to hospitals. If they go to the hospital to deliver, that's when the nurse midwife is, I'm not going anywhere, if it's a home birth sort of thing?
Yeah, so usually a person gets admitted during the first stage of labor, around that active labor phase. So entering that second part of the first stage of labor. Sorry if that's confusing. So you have the early labor, the active labor, and transition in that first stage. And then second stage is that 10 centimeter pushing stage.
So ideally you'd get them right before transition.
Right, exactly. And that's when we try to admit people to the hospital. That's when a lot of people will be calling their midwives for home, because that's when it starts to get really hard. And that's when things progress and are regular on their own. And it's really interesting. Some studies have been done that show if you admit a person too early, you can slow down their labor, or it can stop altogether. Just from the admission process and coming to the hospital and that whole ordeal, and then they get to their room and 3 hours later it's like their contractions
nothing's really happened.
Yeah. So there is benefit to waiting, and that's a really hard thing for a lot of people, is to show up and think they're in labor and then get sent home.
Yeah. Because you don't know what you're doing.
Right.
And then you feel like you've done something wrong. There's nothing wrong with going to the hospital when you think you need to go to the hospital.
Nope.
But you do need to listen to the experts who say, it's not time, this will happen, and when these things happen, that's when you come in next time. And
in most cases, being at home in a familiar environment, with your own food, your own bed, taking a bath, taking a shower, that feeling of safety is a huge part in helping labor progress, which that's not a thing that I can check, right?
Right, and this relates somewhat to the experiences that a lot of women have in sort of the ending stages of pregnancy, is the nesting instincts, which are ubiquitous in all human cultures, that women experience this a zoning in, that their environment comes in, and that the focus is to make this a place where she's going to feel comforted when she gets that place that is very hard.
Right.
That those things are comforting to her.
Right.
All right, so we're in second stage of labor now. I've heard things all about timing contractions. Mm-hmm. Can you talk at all about whether that's useful or not?
So I usually tell my patients that if you can still sit there and tell me how
it's not intense
together, it's true, because everybody. So the biggest rule of labor, when you should call, because people always want to know, when should I call, when should I come in? A very common recommendation is to call or come in with the 411. And we say, when contractions are 4 minutes apart, so that's from the start of one contraction to the start of the next contraction, 4 minutes. When they're lasting at about a minute,
yeah.
And then that's been happening for at least an hour.
Oh.
So you're seeing regularity and increasing intensity, but
I'm so glad I'm a man. I know I would do it if I was a woman. I know I would, because most do, and it's very, very important. It's life-giving. But man, hearing about the pain and about of the 4 minutes, a full one of those minutes, you're just in pain, pushing and having a contraction,
yeah. It's really intense.
Wow.
So that's a common, safety net. That's a good time to call.
Okay.
But usually if someone can be like, yeah, my contractions are every 4 minutes and that's been happening for an hour, stay home, right? I tell people, when you want to throw that contraction timer out the window, then it's time to come in. If you have enough energy to be timing your contractions, you could probably stay home. It's probably not that active phase of labor yet.
What are things that you would recommend to women who are in that sort of, we didn't talk much about this, but there's this weird time lapse when you're waiting to deliver, that time extends for forever.
Yep. So
what do you recommend women do in that, hey, contractions are starting, but this is going to be a long haul?
Yeah, I recommend that people don't time them, actually, when they're really early, because if you imagine, that early phase of labor can last anywhere from several hours to several days. And so if the minute you start to feel some more regular contractions and you're going, okay, I think labor's coming today, I'm going to time it, and you don't actually go into labor, things don't get more regular for 2 or 3 days, you're going to be exhausted mentally and physically, right? So the biggest, best thing for that early phase of labor is distraction or sleep.
Distraction and sleep.
Yeah. Okay. Pre-COVID, I would have said go see a movie.
Right.
Go to the mall. Go shopping. And that's been really hard for people. They're like, I don't want to be at home anymore.
I don't want to be at home anymore.
But my own midwife, I thought they said it really well. Early labor is like the drive to LA. Oh. You don't care about that drive. There's nothing pretty to see. If you could just sleep the whole time and wake up and be in LA, be in labor, that would be okay. So
it's a long haul.
It's a long haul. Early labor is a long haul.
When they get to second stage labor and they're having these regular contractions, it's not a long haul. It's really intense. It's really a heightened environment, and she's not going to be able to sleep.
Usually no. Yes, correct. So if you're not able to rest or sleep in between contractions, if it's taking all of your energy to, just focus on the one contraction and then regain that strength to focus on the next one, then that's when you're getting into that active labor, which, like I said, is usually around 6 centimeters.
Okay. Now, I have not asked for my wife's permission, so I might cut this out, but I will ask her if I can talk about it, because I don't want to share things with you that I haven't asked her if it's okay to share. But she got an epidural 3 times with 3 boys and had 3 very different experiences with those 3 epidurals. The first epidural was with Caleb, her first one, and it stopped all the contractions and it extended labor for forever.
Yep.
The second one with Henry, one of your colleagues, an anesthesiologist, a nurse anesthesiologist at Kaiser, only hit up the left ganglion, not both.
Yeah.
And so she had full one-sided pain, but then this weird thing of none on that side.
Yeah.
And then with the last one, she was at 3rd stage of labor and said, no, I am not feeling any urge to push. Stick it in my back now, and then we can get this show on the road. I'm not allergic to iodine or eggs or anything.
She knew she was about to have a baby.
Yeah, and she didn't want the pain after. It wasn't the pain during.
Yeah.
So she was a veteran, right? And so she knew what these different portions of labor involved, and she made those decisions for herself, but yet she got 3 very different experiences. I think a lot of the pain reduction, pain management things, people think that that's somehow going to solve the problem of pain.
Not always.
And it is variable. It's not necessarily. So could you talk about the choices of using epidural or cervical blocking drugs to minimize labor pain during delivery?
Yeah, since you started with the epidural, we can talk about that first. A lot of people think the epidural is the smoking gun, right? Like, if I get the epidural, I don't have to feel anything at all for the rest of this process, and it's not that perfect. For a lot of people, it is. I'd say the perfect epidural is, if it exists, is one where you get complete relief from your pain, but you're still able to feel the pressure of the descent, so that bowel movement sort of sensation we were talking about, so that you can push your baby out. You're not so numb that you can't move around in the bed, and you feel that pressure, so it helps you know when to push. Because being completely 100% numb, you can't move, you can't roll, and it's extremely hard to connect that pushing sensation, and overall you're probably going to push for a longer period of time.
So you're not really aiding in labor.
Correct.
Yeah.
Right.
Okay.
But then there are those epidurals, and some of it depends on people's anatomy, it depends on how the catheter was placed, it depends on how people react to the medication, or which medication the nurse anesthetists choose to use. And that one-sided pain, or you can get a window, like that one particular nerve.
Oh,
like
wow!
right
Like
here,
didn't get hit up.
just isn't gonna cut it. And it's a gravitational effect, right? So because we don't want any numbness up here, that would be very bad if you stopped breathing, got numb up here during labor.
We want to go below phrenic, so L3, 4, 5 is
Yes.
is that's where you want to stay below.
And because it's gravitational and directional, sometimes we can cover those spots by changing a person's position, but it doesn't always work. So my guess is if your wife had that complete sensation on one side, that they tried to roll her onto that side so that the medicine would go that way, but it doesn't always work. It's not always perfect. A lot of times they have to be replaced, or a lot of times people don't get relief at all. I think one of the biggest complaints that I hear about epidurals is people think that they wear off by the end, and they don't. Usually it's just the baby has descended enough where they're feeling painful sensation again, and usually the best epidurals don't cover that final pressure. And it's actually a good thing to feel that pressure and know how to push, but it can be an extremely sort of emotionally triggering event if you were in extreme pain in your labor, you got an epidural and you haven't had any pain for a really long time, and then now it's time
You hit
to
up the
push,
most intense stuff.
and then you get really intense pain again. It's really hard to get back into that.
Right.
So.
When do you think, if somebody's planning on having an epidural, is the best time to aim for during labor?
We usually recommend during that active phase. So around the time that we hope somebody's being admitted in normal labor, around that 6 to 7 centimeters, because we know the earlier we give an epidural in labor, the more likely it is to slow down the labor. But the later on in labor that we give it, it's much less likely to do that. And so that's, if you think about why, right? You get an epidural, and then what do? You're laying in bed. You're not moving a whole lot. There's protocols now to like flip people from side to side, sit them up, lay them back every half an hour to sort of simulate movement. But if you're a person experiencing contractions who doesn't have any medication, you're not sitting still at all. That's impossible. I have not seen anybody been able
Conscious
to just
who's able to zen through the pain.
Through active labor.
Right.
Yeah, maybe early labor, yes, but active labor transition, I have not been seeing anybody who can just completely sit still. But that's what the epidural is doing. So if you think about a normal labor progression, gravity is really helpful. So you're losing that piece. So if you're already in that active phase where things are really regular and less likely to slow it down.
When an epidural is given, walking is no longer option, and so therefore the primary mode of human movement is taken away.
Right.
And oftentimes women have suggested that walking is a way in between contractions to continue to help them stay fresh and stay ready for the intensity of that pain. Can you talk about non-medical, pharmacological interventions for pain management during labor?
Yeah.
Because that's something that not a lot of people hear about or understand. They think, it's a big complaint I have about our society, we think drugs can solve our issues, but there are many things that can be done to make sure that people have relief of pain during times of intense pain that don't necessarily have to do with the consequential use of pharmaceutical drugs.
Right.
All drugs have a cost. Some drugs are amazing, but other things can be done. Can you talk about the other things that are helpful for women to deal with pain management that are not pharmacological?
Yeah, so one of the biggest things that I think you can start with is thinking of it as a different kind of pain. And one of the books that I recommend is called Mindful Birthing. So using mindfulness meditation techniques, awareness techniques going into labor. And one of those is awareness that this type of pain is different than pain you've experienced in the past. Because what the normal connotation of pain is bad, right?
Tissue damage.
Right.
I'm headed in a bad direction.
Your body gives you pain to tell you that something is wrong, or that you need to fix something. And then you hear the standard narrative, especially on TV and movies, that childbirth is the most painful, the most terrible thing you could experience. So already if you're coming in with that worldview of labor, it's not a setup for success, right? But I really like the way the author puts it in Mindful Birthing. They call it transformational pain. So it's something that's truly transforming your body, right, in a physical way and emotionally, mentally.
Or yourself even more.
Exactly.
Yeah.
So looking at it, starting beforehand, looking at it from a worldview that this is different than the pain that I'm used to experiencing. It's a different kind of pain. A good way to think about it for people who work out or lift weights or run marathons, those things hurt, right? Like you have muscle soreness afterwards, but it's to the effect that you're gaining something, right?
The outcome that you have is better than the pain that you need to get it.
Right.
Okay.
Mm-hmm. So it's pain towards a positive outcome versus pain that is always like your body's way of telling you that something is wrong. So just starting there is something that I try to talk to people during their pregnancy. And then in the actual labor, you already touched on it, right? Movement is one of the biggest things. So one of the worst things we did when we transitioned women or people into hospitals to give birth was to strap them down in bed and say you can't move. And then, it's way harder to just sit still during a contraction. And way harder for labor to progress without gravity. You think you have this mass that's trying to move through the pelvis, and if you're laying back, like you're not getting a lot of help.
Then Mother Earth is gravitationally pulling it through your back, not out the right way.
Right. So if you're standing, that facilitates that descent. We call it the labor dance, right? You've probably seen the sway, and this is where partners are really helpful. We thought, to just dance and hold on. Any kind of movement, different ways to open up the pelvis with lunging, with squatting, being on hands and knees, all of that changes the diameter of the pelvis, which can help facilitate, the baby is part of this too, and they're trying to figure out the best way to come through, and that can help.
We haven't talked about it yet, but during a final transitionary phase, the brain sends signals to the connective tissues that are holding the pelvis to allow them to stretch open even. Mm-hmm. And that movement can also facilitate this process being ready to happen. So movement is a really key factor. You don't want to be moving when your pelvis is open, actually. You want to wait to move until after that passes. But the movement prior to that is really important.
Yeah, and the body's been getting ready for that, like you said, the relaxing.
Relaxing.
Because it's just relaxing all your joints to let the baby come through.
Okay, let's move on to the third, and I don't want to say final stage, but the third stage of labor, what we say, is the delivery portion.
So second stage actually includes pushing and delivery.
Okay.
Right? Delivery of the baby. So is that
Okay.
where you're at
Yeah,
right now?
let's get to that. And then third stage would be placental.
Placenta.
Okay.
Mm-hmm.
So let's talk about the transition then between second and third stage.
Yeah, so baby.
Yeah.
Baby being
the
born.
important element here.
One of my favorite things to do, if someone is up for it, a lot of people are like, no thanks. There's two things actually. Is number one, to have that person touch and feel, making that connection of like, oh my gosh, that's a head, like right there, and I can feel it. I know that it's gonna be over soon. Or using a mirror, like allowing that person to see, this is how close I am. Those are two really like affirmative.
That's a finish
points.
line coaching encouragement that you can use for a woman who's been going through a lot.
Yeah.
To like give her a sense of it's imminent. Mm-hmm. It's here.
Yep.
Okay.
Coming. So a lot of times, even with an epidural, but especially without any medication, that strong urge to push comes with the contraction, right? That fetal ejection reflex. So that contraction comes, you start pushing because you can't stop.
For guys that don't understand this, it's a reflexive thing. Again, think of the buildup of a sneeze. Like, you know it's inevitable, maybe even ejaculation or orgasm, you know it's inevitable. Like, there's that point of no return where it's not happened yet.
Right.
But there is nothing on God's green earth you could do to stop that process from moving forward.
Right.
And you're not in volitional control of it. Like, I can move my hand volitionally. You're not in control of that. So you can ride the wave and push with it, or you could, I guess, affront it and just let nature take its course. But the real movement with those contractions is what women get into and focus on, right? When they're focusing on aiding their body's reflexive behaviors.
Correct. So with that reflex, then the person is then pushing and aiding with pressure from behind the diaphragm and those abdominal muscles to aid in pushing the baby out. So that's where the pushing comes from. And there's still a lot of back and forth about what we call open glottis pushing versus directed pushing. So a lot of people are probably familiar with the counting to 10.
Do you want to take a break?
Oh, is he crying?
I think he might be.
That's okay. He's doing a bottle these days.
Oh, is he?
Got lots of milk.
Okay. That's good. Well, if you want to take a break,
That's okay. Do you need a break?
I don't.
Okay. Yeah. No.
Having adult conversation is really nice.
It's nice.
Because I've been doing just me and that damn camera for all these lectures, and so like having somebody to just hear from and learn about this information that we go through, but then having a real expert here is super refreshing. And it's like, I should have figured this out earlier. I'm sorry, but it's working well for me, and it's cool. Reinvigorating my desire to engage the topic matter, the materials. So we were talking about
pushing.
So
open glottis pushing, which essentially means not holding your breath, right? But I think most people are familiar, especially in the media portrayal of that, and then somebody counting to 10, right? Which isn't based on any sort of science at all. But it's I think where it came from was a desire to intervene, but also a desire to guide, because that reflex and that sensation can feel really overwhelming, and sometimes you do need that
narrowing of focus.
What I've found to be more successful is especially that overwhelming sensation happens for a lot of people who plan to have pain medicine and then
for whatever reason
didn't get it. Like maybe they show up at the hospital ready to have a baby and things feel very out of control and very scary and very overwhelming. Is sometimes I do get like right like up in someone's face, like crawl into bed with them, and it's like, it's you and me right here, and I need you to just focus and do what your body's already telling you to do, versus that, like, if you think about feeling that, the most intense thing you've ever experienced, your initial reaction is going to be to get back. Like, I want to climb the wall.
Withdraw from it.
I want to run away. Just kidding. I don't want this baby. Like, let's go back.
Yep.
Push it back in. Nope.
I watched a video series of people. These were Europeans who, they just put a bunch of cameras up and then had people go jump off of a 10-meter platform. And what's amazing is to watch, it's into water.
Yeah.
And they all climb up, and they've all looked at the 10-meter platform, and they've seen people jump off the 10-meter platform. And they get up to the precipice of jumping off, and their mind does an insane trick on them to, they know that this is something people do. No one's like disappearing after they do this. They land in the water, and then they swim up, and everyone has done this. But this cognitive trick that happens is, I can't do it. That sort of negative feedback of, somehow I can't handle this.
Right.
And despite the fact that we know this is natural, everyone knows this is happening, there's always that sort of element that's dragging women into the negative thought pattern of, I can't do this. This is something you hear so much during labor and I can't do this. Mm-hmm. Which makes perfect sense to say that, because they don't know that they're experiencing something so radically different than anything they've felt before.
Right.
Which, whenever anybody does something they've never done before, they think, I'm going to fail at this. I don't know how to do it.
Right.
And they don't have the present mind. They're so involved in the excruciating pain and unique pain, like you've described, that they don't have this sort of, you know what? I'm going to experience this for the first time because this is a natural biological happenings. It's just, you don't have that presence.
Right.
And so this mindfulness that you're describing is really helpful to refocus on.
Right.
Very simply, a present moment. I am focused on what I need to do right now.
Right.
It gets me nervous thinking about delivery. I know everyone does it, but it literally gets me nervous to think about it.
Isn't it crazy that people even choose to get pregnant and they have I don't care how many books you read.
Here's what's crazy, that they choose to do it again.
Yes.
I do want to talk about the quickest forgotten pain, and I do want to talk about the radical decision that any person could make, which is not to get pregnant or to deliver, but to do that again.
Yeah.
And talk about what's the rationale for it, because that's what most people choose.
Right.
And so it wouldn't seem on the outset, everything we've talked about is, your body's going to transform and you're going to do all this difficult stuff. Why would I want to do that again? And it's really what we're talking about right now. The touch, the connection, the baby.
Yeah.
Is there.
Yeah.
For the first time.
Yeah. You
get to meet your baby, and it is definitely the most transcendent thing.
Right.
I mean, you can stand on the. I watched that movie, the climber guy, Holnid. He's from Sacramento. He climbed El Capitan without ropes or whatever.
Yeah.
And he gets to the top, right? Wow, what an amazing transcendent moment. Everybody gets that. Everybody has that experience when they see that baby. So let's talk about the baby showing up.
The baby being born, right? All of that for the baby. The final bit is that final stretching of the external perineal tissues and the vulva, right? So that's where you hear people talk about the ring of fire, and that is a very real thing, because that, if you think, for most people, that is the biggest thing that has been in or out of their vagina.
Should always be the biggest thing ever to go inside your vagina.
If you
there's
take
some
a look
freaks.
at some
There's some
sex
freaks out there.
If you
we
take
know
a
we
look
haven't
at
got
some sex shops, maybe that is different for some people.
Should always be the biggest thing.
For most people, it's the biggest thing. And so that is your maximum stretch of that tissue. And sometimes it doesn't stretch so well, and that's where you get the tearing.
Oh yeah, I forgot to talk about that. How do you aid the tissue that's being stretched to its maximum allowable tolerances, how do you aid that tissue in not tearing? What are things we can do prior to delivery that will help for this tissue to not tear?
Non-directed pushing.
So non-directed pushing.
Yeah, letting.
Well, I'm not sure all.
Not most.
Okay, back to baby.
Yeah.
Okay.
Oh, so maximum stretch. The literature goes back and forth on hands-on versus hands-off. There's some papers that show that if you place your hands on the perineal tissue and give it some support, like physical support as it stretches, that can reduce the risk, but there's other studies that show, not really. Warm compresses, the same thing, so like a warm washcloth, if you think about tissues that are moist and warm versus stretched
Dried and cold, yeah.
But at the end of the day, if someone's going to tear, they're going to tear. There might have been some things you could do to minimize it or make it a little less, but depending on that person's tissue and their history and their genetics, tears just happen.
Do you know if there's any connection or literature describing increased tears due to the use of drugs, like pharmaceutical drugs, that would reduce your sensation of what's happening?
As far as like epidurals increasing tears, there is some literature that shows that. Yeah.
So that's something to note. If you're choosing to use pharmaceuticals, that might be something that comes along with it, is you don't have a sensation of how that goes.
Right, but then you also don't have the sensation of the repair afterwards. So
there's two sides to every coin.
Right, yeah.
She's talking about sewing together tears that are too big.
Yeah, suturing the tissue back together. And that, a lot of people are still really scared about episiotomy, and that is when we take scissors to literally cut into the perineal tissue to make the opening wider. That used to be a very common practice. A person gets cut to facilitate having their baby, but that is very rare these days, and only used in the case of an emergency where say the monitoring of the baby shows that the baby's in too much distress and isn't going, like the thing that's holding it back is that tissue from being born, but that's really rare these days.
Okay. So heads touched.
Yep.
Mom's pushing.
Yep.
And the head is about to come out.
Right.
What's happening now?
So the cardinal movements of delivery. Most babies come out what we call occipital anterior. So the occiput being that backbone of your head, anterior meaning facing up towards the ceiling. So they come out staring at the floor. Most babies come out that way because that diameter of head circumference, not diameter head, those are two separate things. That diameter is the smallest it can possibly be to fit through the pelvis. Versus if you have a baby who comes out looking straight up at the ceiling, where we call that occiput posterior, that diameter is wider and it's harder to come through the pelvis. But some babies do, it's just harder. It usually takes a little longer. So most babies will come out looking down, occiput anterior, and then if you just leave your hands off, they will rotate all by themselves. They'll rotate to either side, and then the shoulder, that anterior shoulder, comes underneath the pubic bone, and then the rest, the posterior shoulder delivers, and then the rest of the body comes out.
We're going to be watching a video showing an MRI rendition of this happening in real time, so you'll be able to see, as she's describing, the head roll, and after the head comes out, which is the largest portion of the baby in a diameter portion, then the movement of the shoulders, you'll see those things happening.
Right.
And what's cool about the MRI is that it shows not just the external portion, which all you see is a head coming out, but it actually shows the physical body of the baby turning
rotating
inside, and it's a really neat thing to see, whereas you probably can see that by looking at an abdomen, right? You can probably see that transition, whereas the untrained eye won't be able to notice that that's happening internally.
Right.
And so the shoulder...
Also, some woman gave birth in an MRI, and you have a video of it?
Yes.
That woman...
It's not the typical MRI.
Okay.
It's using MRI technology to show And it's a
Who volunteered to give birth to an MRI?
Well, we also show the MRI of people during coitus, which is another. How did you?
I have read those papers. I know there are people who sign up for that.
How did you? And how would that? And what?
I think pharmaceuticals were involved.
You would have to. There's. Not were involved. I think they would have to be pumped continuously.
Required.
Nonetheless, it is fascinating to see internal structures, anatomical structures, biology happening in motion.
Yeah.
It's wild.
Yeah.
So baby comes out now.
Yep.
Okay. What are your concerns as a nurse, a midwife, as soon as the baby's out?
Usually the first thing that I'm looking for is where's the cord?
Okay.
Because when you think about babies when they're little, they can somersault in all directions, and they, when they do that, they're actually pulling on that umbilical cord, and that can actually cause it to grow longer.
Okay.
That tension when that cord is in development, and so half, if not more, of babies will have the cord wrapped around their necks, will have it wrapped around their belly, through their legs, around their ankle, just from all of the movement that they've done. So that's the first thing that I'm looking for. Is there a cord that I need to unwrap from around their person in some way?
Now, counter to what most people think, in utero it's fine if the cord's around the baby's neck. What's not fine is when the baby comes out, if there's no way for the baby to get oxygen from its lungs or from the cord, if there's some sort of a stretch or a pull or something that occludes the arteries providing the baby with oxygenated
so that's
blood.
why we're removing it right away, just unwinding it, and that's usually pretty easy.
Okay. And then what?
Then the common practice now is to put the baby right on mom's or that person's belly.
So you've been doing this for now 10 years-ish? 6 years?
Yeah.
Okay. So prior to this, there was actually a movement where, I don't know if you can hear this or not, but that wasn't the first place where babies were traditionally taken.
Right.
And what changed so dramatically was this idea of understanding body temperature regulation for babies, and that there is not a medical device that's better than a mother's breast for the baby to self-regulate, right? Remember, the baby's been pickled for all these years in that wonderful, or all these months in that wonderful amniotic fluid, just pickled there, and never had to deal with external pressures of temperature regulation.
Right.
And now, bam, put the baby on the mother's chest, and that acts as a heating. What else are you thinking about of why it's important for a baby to be on the mother's chest?
It's really
bare chest, not gown, not bra, bare chest.
We call it the golden hour because there are so many hormonal and chemical reactions that are happening that you can't see, but are just like pure biology, right? Temperature regulation you touched on. Babies who are just left on the belly near the breast. You can probably find a video of this. It's called the breast crawl. Babies can smell the nipple. They can see it. That's one of the reasons that nipples, areolas get darker and larger during pregnancy, is so that the babies can essentially see them easier.
Visually, if you take the development class, we talk about babies' development of vision. What they can see are contrasts of large round objects.
Right.
So that's like and they can see about that far from their face.
Right.
So they're biologically prepared for, the breasts are ready for that engagement.
Right. Yeah. So if you just leave them, they will like work their way up. The videos are incredible, and then like now their way to the
now I have
nipple.
to find a video of that for you.
You should.
Okay.
It's so fun to
I haven't
watch.
seen that, and I want to see it now.
The breast crawl.
The breast crawl. Okay.
That's where the breaststroke came from.
Your babies can't crawl yet, so don't
don't leave them on.
No, your baby can't crawl yet. But we'll talk more about that.
And then that initial like saliva from the baby, the movement of the baby, the like kneading that they do with their hands starts to engage that milk production, because you don't have breast milk right away, right? You have that thick, juicy colostrum that's been sitting there waiting. It's really high in calories and but that will stimulate that production as well. And then they also, just being skin to skin helps regulate baby sugar, which if you think about a baby that's been constantly connected to a food source, constant intake essentially, and then you cut that off, especially for very large or very small babies, it's really hard to regain that sort of sugar control.
Okay.
And so being skin to skin is really helpful for that.
All good things with being on the mother's breast.
Mm-hmm.
All good things to be there.
Yeah.
Okay. Can we talk a little bit about APGAR, the assessment of the baby from a physiological standpoint that you're doing as soon as it's delivered?
Yes. I think I remember all the things. I think APGAR came from the person who named it that, correct? So there's a couple things you're looking for. The first and biggest one is the heartbeat.
Okay.
And there's a scale 0, 1, and 2. I don't remember all of them off
Me
the top
neither.
of my head. I'm sorry.
So it's
You'll have
not-
to give them a scale.
Yeah, it's not something that you're not concerned about doing an APGAR score because you're looking at the baby and clinically assessing
Right.
how is this baby doing physiologically with this brand new transition into, the air.
Right.
What are things that are indicators for you that switch in your mind more focus on the baby rather than this is all going normally?
Rather than like assigning a number and doing that task.
What are which I find to be far more clinically relevant tools than rigid things.
And the APGAR scores are helpful, I think, particularly for data purposes, to say like, okay, an APGAR score of this or less, we can usually expect these
Have an
kinds of things
intervention.
to happen.
We're going to do intervention.
Right.
Yeah.
But if I see, we'll talk about the good things I want to see, right? I want to see a baby that has good tone, which is like curled up, like really, all the limbs are in close. I want to see a baby that's turning pink, and that's crying. If I have those things, then I know I'm okay.
Okay. You don't care what kind of crying? No? Because babies are variable.
Right.
And they come out, some cry a lot, some cry a little.
Yeah.
But you want to hear something.
I want to hear some sort of effort.
Okay.
And that's part of the APGAR scoring is grimace, breath, and cry, right? So are they like looking upset about something? Are they responding to stimuli, being the outside world? Are they making any sort of breath efforts? And then that tone that we talked about, are their limbs in?
So let's assume we have a baby on the mother's chest. This is within a minute of delivery, yeah?
Right, yep.
And you say everything looks good with the baby.
Yep.
What's the next thought in your mind about what do you have to do to help her?
I'm watching for bleeding.
Okay.
That's my next big thing. Okay, baby's good. What's happening down below?
So the transition is, I need to worry about bleeding because this is a dangerous time for women when they could lose so much blood based on what's happened.
Right.
Specifically with separation of the placenta,
Right.
that these are things that now your mind shifts to tracking if she is doing well with bleeding.
Correct.
And what are those things that should be happening naturally that help the bleeding to be assuaged by the natural biological mechanisms?
So usually there is a surge of a woman's own oxytocin. It's like one big final round of contractions. The contractions aren't over once the baby's out, unfortunately, which surprises a lot of people and it's very uncomfortable. But the contraction forces of the uterus, you think about something that's...
It is very good because it gets your uterus back towards where it should be rather than its inflated status.
Yeah, it used to be up here, right? And now you've lost this thing that was taking up all that space. So it's contracting down, and part of that contraction is also going to help shear the placenta away from the side of the uterine wall. So if you think about like a flat surface and something that's globbed onto that flat surface, which is what the placenta is, and then it contracts around it, that then has to start to pull away. But when the placenta, where it attaches, that's all a huge network of blood vessels, right? And so once that detaches, you have this big pancake-sized open wound, just that's pumping out
arterial blood.
Right, like up to half a liter every couple of seconds, right? You could just like crank it out. And that's why women and people die of postpartum hemorrhage still in highly developed countries. It's a huge...
She says still. Rarely. We rarely lose women to abnormal uterine bleeding post.
Still more than we should.
Well, yes. Okay, yeah.
Yeah.
But this used to be what killed most women.
Right. Yeah.
This used to be the most dangerous thing that happened.
Right.
And thankfully, we're getting better. And it's because we have skilled people that are watching and can intervene in terms of helping with women, helping push the uterus as it's contracting after, right? This is a technique that nurse midwives have used for a while, is to add pressure to a contracting uterus.
Fundal massage.
Thank you.
The
can't remember
fundus
stuff.
being the top of the uterus, and then massage. So if
massage.
I reach,
They're jacking it. They're not
Nice
giving it a
word.
nice massage.
If I reach in and it feels like squish, right?
Yeah.
Then I know that's a problem. I want to feel
The tonicity of the contracting uterus.
Right.
Okay.
I want to reach in and feel like a grapefruit, like a hard, firm piece.
So that fundal massage is aiding the actual contractions of kind of squeezing down around the open wound of removing that placenta from the side of the uterine wall.
Right. So once the placenta is detached and makes its way through the cervix and out of the vagina, those...
Which doesn't hurt, isn't a hurtful thing compared to the baby, but it's still a weird thing coming out of you.
Yeah, it's not painful, but it's different.
Okay.
It's still a large thing that has to move.
As I've said before, look at the placenta. So cool.
So cool.
So cool.
But yeah, then you have that big bed of blood vessels, and a uterus that's not contracted, those blood vessels are open and flowing, right? Versus a uterus that's contracted closes off those blood vessels and keeps them from pouring out that blood that was supporting the baby.
So what are the indicators that you can see and say, we need to focus on this bleeding issue now?
Any sort of audible blood flow is bad.
Okay.
That's like
Audible.
yeah.
Audible.
Like I can hear it hitting the floor or the table. That is like, I want all hands on deck immediately. This is an emergency.
Right.
Audible blood flow, never a good thing.
Okay.
Especially after delivery.
Okay.
Any bleeding, like large bleeding that's happening before the placenta comes out.
Okay.
Can be a warning sign.
Got it. That heightens it, piques your interest. I'm gonna pay direct focus and attention on this.
Yeah.
Okay.
It's really amazing. Consistently over decades, they have found that practitioners underestimate blood loss for delivering people across the board. It doesn't matter how long you've been practicing. It doesn't matter, whether you practice in a hospital, you're a midwife or a doctor. We all suck at it. Like it's bad.
There are so many things people are good at estimating and stereotyping, and then there's stuff that we just have a complete blindness to.
Right. So one of the maternal quality care initiatives in California is to do quantitative measuring. So when someone delivers, we put a drape underneath their bottom.
That catches.
Yeah, and it's a clear drape that's marked with, how many milliliters of fluid is in the bag. And then we have standardized things that weights that we know for our towels that we use or for our chucks pads underneath that we use. And we are encouraged to weigh those items in the moment to say, okay, this is where we're at.
You're talking about an initiative that was started here in California by Stanford University and the ACOG sort of board that wanted to unify around protocols for that last bit of women that we're still losing in childbirth that's unacceptable in our society.
Correct.
And what's happened is we've had a tremendous change in the last 10 years here, specifically in California, with maternal health outcomes.
Yep.
And postpartum health outcomes are on par with France, which is the world leader, and we're approaching a real triumph here in California which is not to say it's not terrible to lose a woman in a postpartum environment. It is terrible. I think that may always happen because of the dynamics. But what we have seen is a real thing that needs to be exported. It needs to go elsewhere. It needs to not just be California.
Right.
Because we, you hear all the time, the black women are suffering more in childbirth than white women, Hispanic women, Asian women. Not here anymore. We're closing that gap more rapidly than anywhere in the world, and it's because of the protocols that she's talking about, which is to objectively measure something. Standardized response. These protocols will save lives. Mm-hmm. So whatever you can do, promote that everywhere in the world.
Yeah, it is the basis, having practiced in other states, that
oh yeah,
protocol.
you've done this elsewhere.
Yeah. Mm-hmm.
Okay.
So California has been setting that standard, which is really nice. But yeah, having objective measurements, quantitative measurements, and standardized response is the two biggest pieces for that particular case.
A standardized response means that it's not a doctor or nurse midwife who's saying, maybe today I'll do this. It's, these are the indicators, I do that.
Right. I see this much blood, I am giving these medications, I'm calling these people in to help me out.
Okay.
Yep.
And that's actually probably nice for you in terms of the standard protocol allows you to initiate action and then be thinking rather than have to think to initiate action.
Right. It's just
and then you're going to be able to be more present and more aware and seeing all the things rather than just this very narrowed focus on how do I make a decision about somebody who's crashing.
And we train our teams to that too. So I'm one of the educators for our critical events training team, which is required once a year for our entire nursing and provider staff. We cycle people through and we run these drills. And we always have a hemorrhage drill. So people get really used to just functioning in that environment and working with the team. And that's critical.
Okay. So we've gone from the first stages of labor through the transition into second stage, through the pushing and the contractions, baby's out, baby's on the chest, mom's been checked, placenta comes out, cord cutting is overrated, whatever, it's fine, it happens. Then what's next for you as a nurse midwife?
If everything is stable, so bleeding is stable, I've repaired any tear that I needed to, baby's stable on the belly or on the chest, then I'm stepping back.
Is the baby your patient?
At Kaiser, no.
Okay.
In a birth center or home birth, yes.
Okay.
So I do, my scope does include neonatal care.
You have both the birth mother and the baby as your patients in the scope of practice
Correct.
of a nurse midwife.
Correct.
Okay.
Mm-hmm.
And then follow up with postpartum issues. What are the things that you're seeing, and what are the protocols that you use to ensure a healthy, happy mom?
So that's what we call the fourth stage.
Okay.
Right, or the fourth trimester.
Okay.
Is that postpartum piece. The physical parts are, making sure that bleeding stays stable, making sure that breastfeeding is going well, and that postpartum pain is well managed. So
Okay.
physically talking to a person about those things, what they can expect. Bleeding lasts for usually up to two to 4 weeks afterwards.
Wow.
Sutures usually dissolve and tears usually heal within 4 to 6 weeks. And then breast milk usually comes in within 3 to 5 days after the baby's born. So just kind of setting them up for those expectations. Here, unfortunately, in the larger medical system, we don't see moms again, or birth parents again until 6 weeks postpartum.
Yeah.
And there is a push to start changing that, to start checking in.
A week out. See.
Yeah.
Is that specifically, and this is my curiosity, for the precursors of postpartum depression?
Mm-hmm. Yep. So the first 2 weeks, most people experience some form of what we call baby blues, which is just that sort of overwhelming emotional transition, loss of sense of self, finding out who you are now, having this other person completely depend on you 100% for everything, reliving your birth story, that's a very like psychologically normal thing to do. Any trauma from that, or how great it was, like just reliving that, figuring out support team mechanics in your household, and then not sleeping, right? So all of that is kind of an emotional like combustion waiting to happen, and it's really normal to feel some sense of sadness or feeling of being overwhelmed during those first couple of weeks throughout all of those major transitions.
Another thing is, and this is a cultural critique, that we live such insular lives. And we live in our little boxes, and we don't have the communities that traditionally people did, indigenous peoples did, where the entire community was affected immediately by the birth.
Right.
And there was constant, wiser overseeing people watching new mothers. And they were wise to this, and they had gifts of knowledge to bring and what to look for. And nowadays, I remember when we went home from the hospital I worked at, Columbia University Medical Center. It was my job. I was at the place I worked. We went home with the baby after we had been taken care of incredibly. It was, again, New Year's Eve. We brought like Martinelli's to share with the delivery staff and stuff. In New York City, New Year's Eve is a special time. And the next day we go home, and my wife and I, competent, professional adult people, felt unbelievably alone and incapable, like you didn't know what you're doing. And you know what you're doing, but it's this real sense. It's this real, there's the waves that you have, and that wave that's low is real, and that happens to nearly everybody.
Yeah.
And even if you know it, the experience of it isn't going to, say, lessen it.
Yeah.
And so having the support around you, having those people who are watching out for you, hopefully nurse midwives can have this more active role in the weeks surrounding rather than the 2-3 months afterwards.
Yeah.
Because this is a serious issue that we describe is the normal one is postpartum depression.
Right.
Whether it meets clinical criteria or not, that's not another thing. But then the last thing that we talk about in our class in postpartum is postpartum psychosis, and that is a separate issue that has to be addressed immediately and directly. And it's not that there's something wrong with the woman, but that there's the potential that she could harm herself or harm the baby. And this is something that nobody wants to do, but it's something that does happen. And if you don't watch for it, if you don't ask about it, if you don't have eyes of somebody else outside the situation on it,
right,
it can be devastating. And there's really good treatment, really good help for this. And so it's not like a devastating thing that you'll never get over. Women who have experienced postpartum psychosis get treatment, don't harm their babies, don't harm themselves, and lead fulfilling lives. So I want to be very clear that you need to be open about the thoughts that you're having.
Ideally, you'd never even get to that space, right?
Yeah.
And I think there still is a lot of stigma around somebody who is having those thoughts. If you think about like, well, I just don't want to be a mom, or I just don't want to be a parent, or I'm thinking that throwing my baby out the window is going to make this all go away, but I can't tell anybody that because they're going to think I'm insane. Right.
Let me normalize this for every single person. You will think about, I wish that baby would stop crying. That will happen to you.
Yeah.
And the thing to do is to walk away and talk to another adult and just walk away from the baby. Babies aren't going to need you right now. In fact, if you get to that place where you're frustrated with a baby, you're frustrated with yourself, you're frustrated, walk away from the baby, talk to another adult, and you'll get back. And the people that don't, the people that isolate, that's where we find problems, and that's where we find people, especially men, who engage in shaken baby syndrome, which is when they're getting so overwhelmed, so frustrated. Oftentimes drugs are involved, oftentimes alcohol is involved, and oftentimes it's not their biological baby. Right. So you need to be watching for these factors that could lead to a potential outcome of shaken baby syndrome. That's, again, something that's caused by moving the baby's head back and forth too much, and they get brain damage from it.
Yeah. Some of the biggest risks for postpartum depression. One is an existing mental health diagnosis or condition, and so for those folks that are dealing with that already, we're like hyper tuned to that.
Vigilant. Yeah.
And then the two other things is lack of sleep and lack of support. So a lot of times if you can just...
All right.
Yeah.
I've taken up so much of your time. This has been wonderfully informative, and I am so thankful you've been willing to share with us.
Yeah.
Are there any thoughts that you think are important for people in a college human sexuality class to know about nurse midwives or labor and delivery, or something that is essential for them that we haven't covered?
I think even just the knowledge of knowing that nurse midwives exist is
Okay.
like a great
You know what?
thing.
I kind of, you're right. That's a good critique. I skipped over that.
That's okay.
Could you give a description of the distinguishing characteristics from say, a labor and delivery nurse,
Yeah.
or a nurse midwife, or OBGYN? Right? The distinguishing characteristics of the jobs that they do.
Yeah, so I'll start with the difference between a nurse midwife and an OB, because even a lot of times people who get scheduled with me in the clinic are like, what are you? What's a nurse midwife? And the big difference is in the way that we're trained. So I'm master's level trained versus having a medical degree, and OBGYN has a medical degree. And my specialty is normal labor and birth, when we're talking in the context of labor and delivery only. So routine, low risk, healthy people who are having babies. And then my scope of practice still includes taking care of people with higher risk pregnancies, or things that are beginning to be outside the realm of normal and labor, as long as I'm consulting with a physician. And then OBGYNs are specialists in those high-risk pregnancies, labors that are outside the risk of normal, and they're trained as surgeons. So I want my OB around. It's not a, especially in our practice, it's not a competition, which I think happens a little bit more in private practice, because OBs can also take care of normal, healthy women, and people giving birth. But for midwives, that is our bread and butter, that is our specialty, that's how we're trained. And the other way that our training is different is we're trained to see the patient as a partner in their care, really as leading their care, and I'm just kind of there as a guide, versus telling someone what to do in a more medical model.
Okay.
And then the labor and delivery nurse has usually at least a bachelor's training as a registered nurse, and offers the labor and medical support during the labor and delivery process, including administering medications. That emotional support is a huge part of labor and delivery nurses. Monitoring the baby, vitals, that sort of thing.
Okay. Thank you again. You've been a tremendous help for me, and I'm sure a boon to my students. So there we go.